With the permission of the chair, our opening speaker is Dr. Amit Sharma from Arkansas in the United States of America as a consultant cardiologist to speak on update and therapeutic hypothermia and cardiac arrest. Dr. Sharma, please.
Well, good morning, everyone, and thanks for coming this early morning. I didn't realize I'm the first speaker. So my name is Amit Sharma. I'm a cardiology fellow, and prior to joining the fellowship, I directed hospital medicine at University of Alabama, Birmingham, and I was trained by Dr. Nanda, and I very much appreciate his help. And thank you, Dr. Chopra, and the organizing committee for inviting me. And my special thanks to Dr. Murthy, who set the stage for this talk yesterday for me with this presentation of AHA and API initiative and resuscitation efforts in India. So these are my disclosure, really nothing pertinent to this talk. So it's clear that number one killer in the United States is sudden cardiac arrest. And we heard from multiple speakers yesterday that no doubt the number one killer in India is indeed sudden cardiac arrest. It's about 500,000 people die in the US every year because of sudden cardiac arrest. And really perception that this is the number one killer remains very poor, not in general public, but also among healthcare providers. We have different walks for breast cancer survivor, AIDS, you have different kind of ribbons, but there is still very, very poor perception that indeed most folks are dying of sudden cardiac arrest. So these are some sobering facts. So a 40-year-old American male has 1 in 8 chance of dying of sudden cardiac death. And the average age of adults dying of sudden cardiac arrest, they're not in the 80s or 90s, they're in their mid-60s. And in the last few years, I've taken care of several Indian patients, and I'll show you a case of one. I bet the average age of folks dying sudden cardiac arrest in India is probably in 30s to 40s, and this is very troubling. So I like history in medicine. I have to show this slide, and I showed the same slide to American College of Cardiology, so it's not that I'm in India showing the slide. So I've digged in very depth, and really resuscitation started in India. This is the first documented resuscitation in the history. We all know Lord Lakshmana had a cardiac arrest, and you can see here Ramchandraji is maybe massaging his heart, and in Kamban Ki Ramayan, there is a clear description that Ramchandra actually massaged the heart, so probably the close chest compression of those time, while Hanumanji brings Sanjeevani Booty, maybe epinephrine or amiodarone of that time. So something happened, we knew it 5,000 years ago, how to resuscitate dead. Something happened and we forgot that art. And in 18th century, 17th century, we started re-experimenting. So this was a popular method to hang the dead upside down and in the hope that they would start breathing. Torting or throwing a dead one on a horse and making the horse run that would move the diaphragm up and down was a popular method. On the right side, this was supposed to be the class 1 recommendation from Lancet. This was published in Lancet 1909, and this came actually with a very strong recommendations by physicians then that if somebody is dead, throw them on a barrel and rock the barrel. By doing that, you would move the diaphragm up and down and in the hope that the patients would live. So certainly the focus was all respiration. We didn't have the insight that this is all about heart, and that's a major paradigm shift that happened about 5 years ago, that it's all about circulation. Circulation first, then the respiration. This one is my favorite from history. So this is what German doctors were doing. So a German doctor, when a patient would have a cardiac arrest, a German doctor would actually insert a pipe and would actually in the anus and really would deliver tobacco enema, because tobacco was thought to be the mysterious and the omnipotent drug, and if you give tobacco to patients, they would wake up. So certainly, I thought it was quite funny, and this is definitely from the history. Now, coming on the serious note, this is the patient I took care of 3 weeks ago, and I was talking to Dr. Gulati of Metro Hospital yesterday. I will have Dr. Gulati follow up this patient. He's still recovering in our hospital. He's discharged, but still in Kansas City. So this is a 37-year-old. Look how young this person is. 37-year-old Indian business executive who came for a business trip to Kansas City, suddenly collapsed at the airport. While he was collapsing, there was a janitor who was standing right there. He didn't waste even a single second, and he started hands-only CPR. The wife, who was the dentist of this Indian executive, was actually with him, and she thought that her husband was having seizure. So she kind of asked the janitor not to press so hard, but janitor didn't listen and say, well, this is cardiac arrest, and continued the chest compression. The security guard got AED. The AED device shocked the guy one time. The EMS personnel arrived. They actually they did continued the chest compression, defibrillated him twice. Return of spontaneous circulation happens. Within 45 minutes, he was in our emergency room. We started therapeutic hypothermia, and EKG confirmed it was the RCA STEMI. He goes to cath lab. He's extubated third day, and the first thing he asked was internet and a masala chai. He really had no recollection of what happened to him. So this was really a account of successful resuscitation, and I've been really troubled by how young Indian patients we are seeing with cardiac arrest in the United States. This is really astonishing. So if you think that I'm here to claim that St. Luke's Hospital saved this patient's life, it's not true. I'm not here to boast about the hospital. This patient survived because of the effort of the janitor and the airport staff. If you think that the safest place to have cardiac arrest is a U.S. hospital, you're wrong. Indeed, the safest place to have cardiac arrest in the U.S. is a casino in Las Vegas. So this is all evidence-based. So casino and the major airport in the United States, they're the safest place to have cardiac arrest. So in casino, if you've been to a casino, you would see fancy chandelier, lot of decorations, lot of flowers, and between those decorations, you have millions of cameras that are hiding there. And the minute you walk in a casino, each and every move is recorded. So wherever you're going, except for the restroom, everything is being recorded. So the investigators thought, well, these folks who are visiting casino, they're so closely monitored, why don't we make a use of it? So this was a prospective study where they trained all the security officers in the casino in BLS. So if you go to Las Vegas, every security officer has to have a BLS training before they start the job. And this is what they observed over 3 years. The interval from collapse to CPR time in Las Vegas was average was 2.9 minutes. Now realize, there's variation of 2.8 seconds. That means there were few patients who got CPR within 1 second. That means if the security officer is right there, they would initiate the CPR right then and there. What does this translate to? This translates to super survival. So 59% survival in Las Vegas casino. And how do we actually do in the US hospital? Terribly bad. So if you're in a US hospital, your chance of surviving is not more than 25%. 6 to 25% based on the study you quote. Okay. Now, you may actually argue and say, well, you're sick to start with. That's why you go to the hospital. How can you compare a patient to somebody who's enjoying Las Vegas casino? And the answer is this study. This is from the National NCDR database. And really, they looked at what happens when a cardiac arrest happens to a physician or to a nurse or a visitor. So a visitor should not be any more sick than a person in Las Vegas casino, right? So they actually looked at what happens when a cardiac arrest happens to a hospital staff and a visitor, and this is what they were able to show. Still, if you're a visitor in a US hospital, your chances of walking out of the hospital is 23%. This is astonishing, 60% in Las Vegas casino and 75% at the major US hospital. This is Phoenix, Arizona data, where 3/4 of the patient, if they have cardiac arrest at a Phoenix airport, would walk out of the hospital. So what are we doing wrong? So why hospitals are doing bad? And the reason I'm stressing is it's a good news for our country here in India, because this is the message I want to pass on, and you need to pass on to your trainees and to the nurses. This is what we do wrong in the hospital. So if there is a suspicion of cardiac arrest, it takes about 12 minutes, sometimes up to 12 minutes, to recognize that the patient has cardiac arrest. Because the nurse would call the nursing supervisor would say, let's get the BP, some nurse would say, let's check the blood sugar, and the crucial time would elapse. Versus if you're at the airport or at the casino where they know only one thing, if a patient is down, has collapsed, anyone who has seen or heard collapse should get immediate chest compression. The other important message I want to take you, for you to take home is the pulse check. We've been hammered here in the Indian medical education to check the pulse and check the pulse and check the pulse, and same thing we do in the US. And the problem is we're not good at recognizing whether the patient has pulse or not, and this is a very nicely done study where really what they did was they randomized two sets of patients. One were actually going for CABG, and the other half was actually really having the bypass surgery. So as you know, when patients they undergo bypass surgery, they have no pulse. So they took about 35 physicians, a small subset, but a very important message from the study. And they say, well, go tell if the patient has pulse or not. And if you see on the right-hand side, about 60% of the time, physicians said there is no pulse, when actually there was pulse. And importantly, if you see the middle side, about 10% of the time, there is no pulse, but a physician would say, I feel the pulse. And that happens all the time at code blues or resuscitation efforts. You will be resuscitating somebody who say, I feel the pulse. Somebody say, I don't feel it. It's a chaos. So the message is, your accuracy is hardly 65%. Now this is the controlled study. You can imagine if somebody is undergoing cardiac arrest, it's a chaos, it's an emotional milieu for the physician, for the nurses, for the patients, and for the family. So this accuracy, I bet, in a true cardiac arrest environment is very, very low.
I'm sorry for the interruption, Dr. Sharma.
So bottom line is, don't do pulse check. Okay, I'm going to briefly review the chest compression. Very important. You got to start quickly. You got to push hard. You got to pump fast, and you got to have good recoil. So in the interest of time, I'm going to actually skip this. This is the paper Dr. Chand, who's my mentor at Mid-America Heart Institute, published. Really, you got to defibrillate the patient as soon as you see they have VT and VFib. And indeed, if you do that, 3/4 of these patients, they survive. Few words on airway and breathing. Avoid early intubation. So early intubation wastes time, first 10 minutes. Oxygenation is not the problem. It is all about circulation. I'm going to skip this. One thing, and Dr. Murthy would attest to this. Dr. Murthy is an anesthesiologist. He's sitting right there. So ambu bag is designed to be used by the anesthesiologist. And what we do as an internal medicine or the cardiology doctor, we love to squeeze the hell out of this bag. And when you do that, you increase the tidal volume to about 1,500. That reduces the venous circulation and certainly causes harm. This is a landmark study by Dr. Gordon Evie that really changed how we do cardiac resuscitation. And really what Dr. Evie did in Tucson, Arizona, he trained every single, at least he tried training every single individual in the city of Tucson to deliver chest compression only CPR. Really no breathing, no rescue breathing was introduced. And this is the result, at least 3/4 survival if you do chest compression only CPR. So a question comes up all the time, should you still do rescue breathing if you have 2 or 3 people standing right there? And the answer is no. Rescue breathing is harmful. For the most part, should not be done. Do chest compression CCR. I'm going to skip ACLS drugs, but one slide. Drugs don't help, so don't waste your time or don't feel intimidated if a nurse is screaming and saying, what is the dose of Ibutylide? The drugs don't work. The drug you need to remember is epinephrine. Okay? Epinephrine by and large, and really beta blocker and immunosuppressant on admission, which you don't have any control in cardiac arrest. I won't have time to discuss therapeutic hypothermia, but I was talking to Dr. Murthy, and I would love to come back and talk about hypothermia. I'm going to skip it. There's an important video that I would like to actually show And this is, hopefully we'll have an Indian version of this video. This is by HA, and I thought this was a very, very good contribution in the science of resuscitation.
Ready? All right.
Movie.
Slingshot.
Flying bird.
Bird.
It's definitely a romantic
Wait,
comedy.
what is my win? No, you drink your
Shirt Man.
The Heart Attack sequel.
Falling down.
You can't tell by the way I use my walk. I'm a woman's man. No time to talk. Music loud. Women want things interact. Since I was born, it's alright. I'm okay. And you may look the other way. But we can try to understand.
This ever happened to you? Harmless game of charades based on film titles turning into a sudden cardiac event? Bam! Shaklacky! No? What? Think you're better than me? Well, it happens, all right? It's a real-life situation. I got my daughters here. Call 911. Push hard and fast, okay? Focus! And yes, the beat of staying alive really works. Sharma! Disco can save lives. Yes, disco, huh? Check it out. What do you think? What? Dance party!
Call 911 or call ambulance here. Really push hard. Center of the chest. Thank you so much for your
Thank
attention.
you, Dr.